Now we will have the next clinical case discussion on carcinoma penis. I'd like to invite Dr. Rajarajan from Kanyakumari Government Medical College for the presentation. I request the chairpersons to remain for the next session also. Thank you, sir.
Good afternoon. 62-year aged male, Mr. Narayanan, residing at Takkalai, working in coir factory. Patient came with the complaints of ulcer over the glans penis for the past 6 months, sir. Initially, it presented as a nodule in the glans penis. Then it ulcerated to form a ulcer, which was about 4 centimeter in size now.
When was the nodule occurred?
6 months ago, sir.
No, ulcer for 6 months.
Nodule. After that, within 1 week, it ulcerated, sir. So it forms an ulcer of size 4 centimeter involving the glans penis.
6 months he has not come to the hospital?
No, sir. He thought some his infection, so he didn't come, sir. He get some medical treatment in the medical, sir. It's tablet only. So it is associated with foul smelling discharge, scanty in amount, and occasional bleeding from the ulcer on and off episodes. And there is no history of pain over the ulcer.
Foul smelling discharge from the ulcer?
Yes, sir. How old is he? 62 years old. No other positive findings, sir. There is no multiple sexual partners, and in family history, his spouse didn't have any history of sexually transmitted disease and does not have any vaginal discharge.
So, if the spouse is having sexually transmitted disease, it will be spread to men?
It can spread, sexually transmitted disease can spread to men, sir.
So, carcinoma penis is a sexually transmitted disease?
Human papilloma virus is a cause of carcinoma of penis. It can
My
spread
question, straight question.
No, sir.
Carcinoma penis, is it a sexually transmitted disease?
It is not a sexually transmitted disease.
It is not a sexually
predisposing factor can be a
So, why do you ask the
infection.
predisposing factors for the your sexual partner?
Predisposing factor, human papilloma virus infection can be there, sir, because she might have some condyloma acuminata or
so that means it is spread.
Predisposing factor can spread. Carcinoma of penis per se can not spread.
Oh. So the So they did a large study with the patients, with the ladies with the carcinoma cervix and carcinoma penis, and there is no correlation is there. So both are caused by the human papilloma virus. So somebody who has a carcinoma cervix, the woman, and that's no evidence to say those who have a carcinoma cervix and husbands are getting this, or the reverse. Somebody who has a carcinoma penis and she is getting a carcinoma. So human papilloma virus is a common factor for both it produces. Which human papilloma virus?
Sir?
Which?
Human papilloma virus 6, sir. 16.
6 what will happen? Cause?
Plantar and palmar.
It will do something for the penis also.
Wart, sir.
What?
Very Genital
What is
warts.
Buschke-Lowenstein tumor?
Buschke-Lowenstein tumor is an locally aggressive tumor with verrucous growth, sir.
So it's
It
caused
could
by
be
what?
Human papilloma 6.
Papillomavirus 6.
Six.
So lot of benign papillomas will be there for in the penis also. It can produce that.
General examination, patient is conscious, oriented and febrile, well bit and adequately nourished, no pallor, no icterus, no cyanosis, ECOG score is
Local
1.
examination.
Local examination, after getting informed consent in a well lit room, patient was asked to undress below umbilicus level and examine standing and supine position. Inspection, penis is uncircumcised. So after retracting the prepuce, a single 5x4 irregularly shaped ulcerative lesion involving the entire ventral aspect of the glans penis, extending up to coronal sulcus in the ventral aspect.
So you were able to do the retraction.
Yes, sir. And the floor is covered with minimal slough and the edge without traction not visible, sir. The edges are raised and external urethral meatus is not seen on inspection. The shaft of the penis, prepuce, scrotum and bilateral inguinal appears normal.
External urethral meatus not seen.
Not visible on inspection, sir.
No. So, okay.
A palpation, single 5x4 centimeter non-tender irregular shaped ulcerative lesion involving entire ventral aspect up to coronal sulcus and the part of the dorsal aspect of the glans penis with raised edges. It bleeds on touch and the margins are well defined and base is indurated, not extending.
What is the significance of bleeding on touch?
It could be of excessive granulation, sir, or in case of, it can be a malignancy due
Why?
to immature fibroblast and blood vessels.
So fibroblast will bleed.
Immature blood vessels in the surface of the ulcer.
What do you mean by immature blood vessel?
Ulcer proliferative. It's a growth, active growth is there.
No, bleeding on touch indicates what?
Active growth, active ulcer.
Active ulcer. Anything can happen to active ulcer.
Increased as
Neovascularization.
new angiogenesis.
So in neovascularization produce bleeding on touch.
Angiogenesis will be occurs. The tunica media is not there, sir, in neovascularization.
So all
Only
the
intima is
layers
there.
will be defective. The
Defective
serosa
layers.
and the media will not be there. So even a mild touch can produce a profuse bleeding. Not just touching, oozing.
Base is indurated, not extending beyond the ulcer margins. The ulcer extends over the external urethral meatus, but it is visible, sir. Now,
Which is visible? Ulcer is visible or?
external urethral meatus is visible, sir.
On palpation.
Yes, sir.
So ada kanna moodittu paathe, ada kanna thirundittu paathe.
No, sir. Ulcer, it is
Yeah,
closing the external
I am not
urethral
able to
meatus, sir.
understand. Inspection you are not seeing, palpation you are able to see. I mean.
It is an ulceroproliferative type of growth, sir. So it is covering the external urethral meatus. It is almost distracted, sir. When we are
But the first sentence and inspection you said after retracting the penis, I was able to see that.
yes, sir. After
No,
retracting the
why not
penis-
you say the same thing here also?
Yes. External urethral meatus is visible after retracting the proliferative growths.
You cannot say it is visible as like a normal meatus. It is involved in the growth.
Okay.
So, but there is no urinary disturbance.
No urinary disturbance, sir. Shaft of the penis and urethra is normal. Normal. It is only on glands, no involvement to the shaft.
Yes, but half of the urethra yes, produce some involvement.
Yes, sir.
So the stream will be normal.
Stream is not, when it involves direct invasion to the urethra, it can cause bifid stream. So there is no complaints of bifid urination in this patient, sir.
Okay.
Scrotum, testis and cord structures are normal.
Which one?
Scrotum, testis, cord structures are normal.
Will the patient have any micturition difficulty if it involves urethra?
Patient will have bifid urinations and on straining.
Will it cause
patient-
obstruction to urethra?
No, sir.
Will there be any stricture?
If not, why?
At present, there is no involvement.
No, if not present, why?
Because
how it is maintained?
The tunica albuginea and the Buck's fascia are thickened layer. It prevents carcinoma spread from one layer to another layer, sir. So it takes very rare before the patient will present.
Will it alter the staging? Involvement of urethra?
Involvement of urethra now don't have any significance, sir. In even T3 and T4 with or without urethral involvement, it is same.
Okay.
Examination of the inguinal renal, a single superficial, the horizontal group, hard, non-tender, mobile node of size 2 × 2 cm is palpable in the right inguinal region, and the skin appears normal. Left inguinal region is normal. Per rectal examination, sphincter tone is normal, fecal staining is present, and no prostatomegaly, no deposits. In a systemic examination, no findings. So I give a provisional diagnosis of a non-healing ulcer or the gland penis, most probably of malignant etiology, with right inguinal lymphadenopathy. So I give a clinical staging of CT2 N1 M0. This is stage 3A.
Why T2?
Because it involves the gland penis, it invade the lamina propria, sir. The induration is there, sir.
Lamina propria is T2.
T1. It invaded the lamina propria, so involvement of corpora spongiosum is T2, sir.
Okay.
It involves gland penis and there is induration, so there may be no invasion of the corpora spongiosum.
So what is 1A? What is 1B?
1A is involvement of the gland penis up to lamina propria, prepuce up to the dermis, and shaft of the penis above the superficial fascia. What
is the difference in 1A and 1B?
The lymphovascular invasion, sir.
Lymphovascular invasion. So early itself, the lymphovascular invasion will go for that. What is TA?
TA is verrucous carcinomas. There is
verrucous carcinoma. Yes. So where else you get TA?
In bladder carcinoma.
So only two areas where you report. One is a TA, here, transversal epithelial carcinoma, what you are going to get in the bladder. That also in the staging it comes as a TA. Here it is. So what is the new changes is there in that? HSCC is 8.
In this, urethral involvement is not included, sir. And stage 3 is corpora spongiosum.
That is reverse.
Corpora spongiosum.
And T1 is also divided. Now you have 3 segments. T1 is there. Glands separately, prepuce separately,
and the shaft.
Shaft separately you are going to take. Okay. So N1?
Nodal involvement, when it is a single mobile ipsilateral node, it is N1. When it is multiple or bilateral nodes, it is N2. When it is involvement of the iliac nodes, it is N3, sir, or meta.
Iliac nodes?
Iliac nodes.
Pelvic nodes involvement.
Pelvic nodes involvement is N3.
Or fixed nodes?
Fixed nodes.
So you are only is the mobile node?
Yes, sir.
So how will you proceed?
For my patient, I first like to confirm the diagnosis, sir. So I like to have a USC inguinal region to look for any other nodes, and the USC abdomen for involvement of the iliac nodes.
So that is the primary?
Sir?
Inguinal region is your primary?
Inguinal region, yes, sir. Inguinal region.
Confirmation is only for a primary first?
Work up, sir. I like to work up to look for the extent of the disease, which is a USC of the inguinal region, bilateral inguinal region, and the abdomen.
Growth?
Edge wedge, I will go for a edge wedge biopsy, sir. MRI penis can be taken to know about the invasion of the tumor if we are planning for the penectomy penis preserving procedure, sir.
So how will you do the MRI?
Penile coil.
Penile coil. We know only breast coil.
Don't know, sir. Erection, it should be erectile penis. It should be done in the erectile penis.
So the penis should be kept in the erectile position. Going to do. So what is the intention of doing MRI? Because now the lymphovascular invasion is included, but it cannot be seen by other things. So because lymphovascular invasion will make the staging is going high. Okay. Then you do a biopsy.
Based on the histology, we can go for the treatment of the primary tumor.
So what all are the carcinomas you are going to get at that biopsy? Possibilities?
Possibility it could be a squamous cell carcinoma, sir, or it could be adenocarcinoma arising in the Tyson's gland, or it could be a malignant melanoma.
Can it be a Paget's disease?
Yes, pages disease can also occur.
Extra mammary pages
Extra.
disease can be also come in there. So thinking in terms of a squamous cell carcinoma, what will be the histological features you are going to get?
It will be presence of the keratin pearls with increased mitotic index.
You know what is broader classification?
Broadest classification, the amount of the differentiation they give, sir. Grade 0 is no differentiation. 1 is well differentiated. Moderate 2 is moderate differentiated, and 3 is poorly differentiated.
When you say moderate differentiation?
Ratio of the tumor cells to the normal
How many
cells.
percentage?
30%.
75. You say up to 75,
75.
then 75 to 50, then 50 to 25, then less than 25. Less than 25.
Undifferentiated.
Undifferentiated carcinoma you are going to get. But is it significant now?
Only in case of a young patient, when we are planning for the penis preservation procedure in T1 stages, it is significant, sir. If it is high grade, we should go for a total penectomy. When it is a low grade, we can go for radiotherapy or a glands preserving penectomy. So in that stage, in that condition, it can be grading is important, sir. High
So what
grade or
are
low
the
grade.
pre-malignant conditions? What are the pre-malignant diseases or pre-malignant state?
Leukoplakia of the penis, chronic xerotica, balanitis xerotica of the prepuce,
Barotic,
BXO, balanitis
xerotica
xerotica
obliterans. Okay.
and human papilloma virus.
Human papilloma virus is a pre-malignant condition.
Condyloma accuminate.
Condyloma accuminata. What is condyloma lata?
Syphilis. Condylomata syphilis.
Okay.
Tertiary syphilis.
Condyloma accuminata is
It is due to human papilloma virus, sir.
Buschelov tumor. So what are the other predisposing factors? So you don't have a Bowen's disease, you don't have
It is
erythroplasia
a
of Corret.
pre-malignant. It is in situ carcinoma, sir. Bowen's disease is a carcinoma in situ involving the shaft of the penis, whereas erythroplasia of Kuwait is the in situ squamous cell carcinoma involving the glans penis.
So what do you mean by in situ carcinoma here?
It does not involve breach the basement membrane, and it is now graded as TAS in TNM staging. So
what is the difference between Paget's disease and Bowen's disease?
And Paget's disease, there will be depth involvement, sir. Basement membrane is breached, and there will be vacuolated cells, large Pagetoid cells in the histology, sir.
T Paget's has to be the mass.
Yes, sir. There
No.
will be mass. Well,
Can be the mass, it can be in vitro carcinoma, it can be in situ carcinoma, anything which can be that. Paget's disease per se, it is only cutaneous manifestation of the underlying malignancy. So it can present with, suppose it is a Paget's disease with a mass. So what will be a staging?
It should be according to the mass.
It will be mass.
Mass.
You don't call it as a Paget's. So Paget's per se do not have a mass. Paget's per se do not have it is only a manifestation what we are calling it as. Similarly, Bowen's is only a cutaneous manifestation of the squamous cell carcinoma. Paget's is a cutaneous manifestation of the adenocarcinoma. Extramammary Paget's, similarly modified sweat glands, wherever it produces,
Perineal region.
it can produce as a, that same erythroplasia of Corret.
Erythroplasia, it is in the glans penis, sir.
So squamous cell or adenocarcinoma?
Squamous cell carcinoma.
Squamous cell carcinoma. It is specifically there. So all this has the same histological feature. The Pagetoid cells will be there. So but one is an adenocarcinoma, one is going to be the. So what is the common site of Bowen's disease?
Glans.
It is not shaft of the penis, the back.
Back.
So all those areas you can get, but commonest pre-malignant condition you are going to get in that. So what chances of leukoplakia producing malignancy?
It would be around 40%, sir.
No, it is not that severe. You have a 40 malignancy. Which is more severe, erythroplasia of Corret, erythroplasia or leukoplakia?
Erythroplasia.
Erythroplasia. Leukoplakia is very, very limited. It is a long-standing leukoplakia, especially in the tip only, can produce as that. What are the conditions which stimulate or predispose formation of the malignancy in the breast, in the penis?
Smegma deposition.
Why? Smegma is carcinogenic.
Smegma deposition with poor hygiene causes
Is
irritation.
smegma is a carcinogenic?
No, sir.
It is not a carcinogenic.
It is not carcinogenic.
It is secreted from?
It is secreted from the It has glands in the coronal process.
So what is the function?
It helps in lubrication.
So in a case of phimosis, the smegma is not able to come out. You are not what that stays there, produce irritation and inflammatory reaction goes. Per se, smegma is not
It's not
a
a
carcinogenic to cause lesion. What other predisposing diseases? Any habit? Alcohol and smoking, which one causes more?
Smoking 2.3.
Smoking can
2.3 times more.
Anything else? Somebody who had recurrent injuries to the penis, that is more prone for that. Any therapy in the cutaneous therapies? Dermatologically, any therapy? Suppose somebody has a psoriasis, what do you do?
Sorolin, PUA therapy.
PUA therapy is one of the most potent stimulant. Almost they say it is 200 times more possibility. Somebody who is having a PUA therapy, the treatment for here, and they are more prone for that. But all other tumors like musculoskeletal tumor, and that can also produce as a predisposed. Syphilis?
Syphilis, chronic ulcer can cause squamous cell carcinoma, sir. But syphilis itself doesn't cause. Yes, it heals.
It will not cause.
It may.
What it will cause in the penis?
Secondary syphilis.
Secondary syphilis. It will not produce primary syphilis.
Primary syphilis with a hard chancre, sir.
So what is describe the primary syphilis?
It is an hard, indurated, painless ulcer at the glands
With
and corona.
But
With,
button-like deformity you are going to have. So with this now how you are going to proceed? You are done a diagnosis of a T2N1M0. What is your...
For my patient, I will discuss with the tumor board, sir. Then option of surgery will be partial penectomy with 2.5 centimeter stump with 2 centimeter margin clearance. And for N1...
So you said it is still confined only to the glands?
Yes, sir.
So cannot...
No, sir, it involves both dorsal and ventral aspect. So it is better to go for a partial penectomy since the patient age is 62, complete family.
A single circumcision, is it sufficient or not?
Circumcision, no, sir. Glands, it is involving glands.
Involving the glands?
Yes,
okay. Classectomy, not possible.
Glandsectomy you don't recommend for this.
No, sir.
Okay.
It
Any other...
It crossed the coronal sulcus in the ventral aspect, sir. Coronal, it almost reached the coronal sulcus. It is coronal sulcus. So I will go.
You want to give the clearance.
Yes, sir. 2 centimeter margin. So
2 centimeter margin?
yes,
for the penis? No? Yes.
In some books they are telling us staging. According to staging, we can give clearance. For T1 it is 5 millimeter. T2 it is 10 millimeter. For T3 it is up to 15
T3
millimeters.
and T4 is
10
different
15
things.
millimeters enough,
And
sir.
it is 1 centimeter, the 10 millimeter is good enough for the penis. We don't. Nowadays people start about ing margin. So ing margin was only coming at the 0.5. So what are the organ preserving surgeries?
An organ preserving, glands preserving, glansectomy can be done, sir. Or patient can be opted for a radiotherapy, sir. External beam radiotherapy or pineal mold radiotherapy in form of brachytherapy.
External beam or
Brachytherapy.
so when will you give external beam? When will you see brachytherapy?
External beam. When we
One of the cutoff value in penis is a 4 centimeter. Many areas. So when the tumor is less than 4 centimeter size, the mold will fix in and you can always treat for the mold. And if the tumor is more than 4 centimeter, you must always go for a external beam radiotherapy, not a mold therapy you cannot give. Laser?
Laser can be, NDIAG laser can be tried, sir, but recurrence rate is high after 5 years.
Only NDIAG laser? Can you use a carbon dioxide laser?
Can be used, sir.
What is the difference? So depth of penetration.
Yes.
So how much depth? If it's very superficial ulcer, you can give NDR. Little deeper, you can go for a carbon dioxide laser, depending upon the length. So any chemotherapeutic drugs ointments can be given?
5-fluorouracil or imiquimod can be tried in carcinoma in situ.
What is the difference?
5-fluorouracil act upon the dehydrate reductase mechanisms and prevents cellular proliferation by inhibiting the formic acid.
So what is the dose?
50.
Putting an ointment like that. It's a
topical
BD,
application, BD.
morning and evening. The immaculate you should not put in the morning. You should only put in the
Night.
Night 3 times you can put, but not in the day sunlight exposure. What is photodynamic therapy? Photodynamic therapy? Amino levulinate, okay. Methyl amino levulinate when you are putting. So it sensitizes when the light, particular wavelength light you are passing, it sensitizes the porphyrins in the tumor cells. The porphyrins will be stimulated and they release lot of free radicals. These free radicals will form as the tumor necrosis will be. So that is one major aspect. Now lot of ablative therapy, one of the important ablative therapy it's been used is a photodynamic therapy, which use the wavelength of the light which is amplified by the methyl amino levulinate acid. The main is the porphyrin. The porphyrins in the tumor cells go for degradation and release the free radicals, and that is going to destroy the tumor cells. So all these are so it is not there because this is already a large size tumor. So you are going to do
partial penectomy with a bilateral inguinal node dissection, sir. Sir?
What inguinal node dissection you are going to do?
Modified inguinal lymph node dissection.
Why not Dressel's quadrangle? What is Dressel's quadrangle?
Dressel's quadrangle is between the pubic tubercle and the anterior superior iliac spine, and medially by the lateral border of the adductor longus, and laterally by the medial border of the sartorius, and apex.
Lower end?
Sir?
Lower end.
Lower end it is 15 centimeter from pubic tubercle and 20 centimeter from the anterior superior iliac spine.
So what is the modified Catalona operation?
Modified Catalona operation is the superficial inguinal node dissection, sir. It involves in a sentinel lymph node. After sentinel lymph node biopsy, superficial nodes are removed, and it does not breach the fascia lata.
So when will you do
preservation of the saphenous
ilioinguinal dissection, or when you do the superficial node dissection?
When there is a N0 node, we go for a sentinel lymph node biopsy, and we will proceed it. If it is positive, we go for a superficial node dissection, sir.
If it is negative?
There is palpable.
If it is negative?
If it is negative, we can go for a radiotherapy also.
No. Why do you want to go radiotherapy when it is negative?
Oh yes.
When your FNAC is going to be negative, you should do a excision biopsy. Just if the node negative FNAC, excision biopsy. If the node is positive, you are going to do the superficial lymph node dissection. So doing a superficial lymph node dissection, when will you convert it into the inguinal node dissection, pelvic node dissection?
When it is more than 2 nodes extra nodal
more than 2 nodes? Are there any nodes with the extra nodal?
With positive 2 nodes with extra or nodes with extra nodal extension.
Or if you see the clocket node.
Yes, sir.
Clocket node is always a pathway between the inguinal. So once the clocket node is involved, that means can you get a clocket node directly without involving the inguinal nodes?
Yes, sir.
When?
It supplies the corpora.
Not corpora. It is especially in your case.
Glans penis.
It is from the glans directly. It can go to the clocket node bypassing this inguinal nodes. So all these conditions. So what is the boundaries for the iliac node dissection? So upper bifurcation of the
Iliac.
Common iliac. Laterally
Pubic.
Genitofemoral nerve. Medially bladder. Lower end is a obturator. So upper is a bifurcation of the common iliac. Genitofemoral nerve, you identify it as the lateral. You go up to the mucosa of the middle border of the bladder, and so what are the complication of lymph node dissection?
There could be lymphoria, lymphedema of the lower limb.
What is the dreaded complication?
There can be infection, sir, which can erode into the femoral vessels and cause blowout.
So blowout. So what you will do?
We can use sartorius can be mobilized and close to the femoral vessels.
So now a question was very, it's other university question. What are the steps you will prevent the lymphoria or the lymphedema in the when you are doing the inguinal dissection? What are the steps you can take to reduce the lymphedema?
Saphenous vein is preserved, sir.
No, that is modified Catalona operation. Even before that. Huh?
Incision.
Now doing an endoscopic dissection. One is the first we are going to do only the laparoscopy or endoscopic dissection, that is one. Modified, not the Dressler square triangle, modified. Then what else? What is the most important enemy for developing lymphedema? Infection and compression. So your bandage should not be too much compression, and you should not put any infection. So the continuous material should be there. There are now a lot of even metallic beads they are putting there to prevent. The steps are there to prevent the lymphedema. Okay. So in this case you will do partial penectomy.
Yes, sir. Partial penectomy with bilateral inguinal dissection.
Okay. What is the prognosis?
Still he is saying bilateral dissection. Is it agreed as?
There can be crossing of lymphatics or the base of the
Bilateral
penis.
superficial lymph node dissection. And if that is positive, then you will go. Otherwise, you don't go that. Okay. Any questions from FNAC of node? Absolutely. You have a role of FNAC of the node. FNAC is negative, still you need to do excision biopsy. FNAC is positive, you need to do the superficial lymph node dissection. And that two nodes are positive or the clocked node is there, then you should complete the node. Now that is no more that's followed. Antibiotic approach, wait for the 6 weeks, we don't. So you go the FNAC. The sentinel node biopsy, is it indicated? We call it a dynamic sentinel node biopsy. Not a single, only the blue dye, only the technetium. It is a combination of the technetium and the blue dye can be done, sentinel node. Which node will be involved? That is also disproved now. Cabana node is not the first node mostly. That is when Cabana was identified, he said that is a node. But now need not be a Cabana node. That other nodes can be also involved. So sentinel lymph node biopsy can be done. But now within our setup, it is an FNAC is a better option. Do FNAC. If it is negative, do a biopsy. If it not that. So if the N3 nodes, there is a fixed nodes. Give a radiotherapy. So what are the indications of radiotherapy for carcinoma penis? One is a locally advanced, not operable with the painful ulcer. You can only, no other way you can go. Or the nodes, when the fixed nodes, that you can give a radiotherapy. Look for the residual node depending upon the salvage surgery you do or not.
So according to urological society guidelines, if the lesion is high grade, they can directly go for ilioinguinal block dissection for a T2 lesion.
The lymphovascular invasion is there. The high grade tumors, the squamous cell carcinoma itself, when they are reporting it is a very high grade tumors, they are always going for that because they proved that the chances of involvement of this is very high. The T1 lesions, when it is limited, no lymphovascular invasion, then only the possibility is less and there is no need to do that. Because one of the most important deciding factor is the node. Like wherever the squamous cell carcinoma, T1, N1 will be stage 3. Just N1 itself will be stage 3. So you need to be importance to the N1 stage will be there. Okay.
Thank you, everyone. I humbly request our HOD sir, Professor Dr. JAYALAL sir, to present a token of gratitude to Professor Angeline Vincent ma'am and Dr. YUVARAJ sir.